Hello, I'm Dr. Bill Gradishar. I'm a professor of medicine and breast cancer specialist at Northwestern University, where I've been on the faculty for the last 36 years. I look forward to having a discussion today with you about the way that chemotherapy use in breast cancer has evolved. And I guess the first thing to know is that, back in the day, and this goes back a long, long time ago, chemotherapy drugs were few and far between, and the few that did exist were largely for the treatment of leukemia, which is where the use of chemotherapy was initially started when the oncology field was really, really, really in its infancy. And because we only had a handful of drugs when we started treating solid tumors, and quite frankly, that was a bit before my time as well, it was using the same chemotherapy drugs that were used to treat leukemia. And as drug development evolved, we started to have more choices in chemotherapy. And as a result, the drugs that were used were tailored to the disease that you were trying to treat. But initially, way back when, several decades ago, the use of chemotherapy was largely modeled on one size fits all. And the other thing that was often appreciated at that time was because in preclinical, in other words, in the laboratory or in animal models, it looked like the more you gave, the more tumor cells you killed, that more must be better. And we also learned over time that that is not necessarily the best strategy. I think one of the things that we've come to appreciate in the last many, many years is that chemotherapy drugs are not just a different flavor, but they work in different ways on the tumor cell. We talked today about tailored therapy or targeted therapy, but in many ways, chemotherapy is also a targeted therapy. It usually works on some part of the tumor cell, and each of these drugs have a potentially different way of acting on the tumor cell. So when we think about chemotherapy drugs, they're really targeting the tumor cell, but they have some off-site side effects. So in other words, they don't only affect tumor cells, they can affect normal cells. And we'll come to that in a bit, but that's why the side effects that are accompanying chemotherapy are so noticeable to patients, because they're not only affecting tumor cells, but also normal dividing cells. So as the use of chemotherapy became more standard in solid tumors, we started to adopt the idea of putting chemotherapy drugs together to make cocktails of drugs. And the rationale for doing that was because each of these drugs potentially acts in a different way on the tumor cell. So coming at the target, the tumor cell, in different ways with a different combination of drugs was very appealing. But as you might imagine, when you start making a cocktail that has several different drugs in it, or two or three in some cases, the potential for increasing toxicity or side effects also increased. So when these drugs and recipes were being developed, they had to be modified in order to maintain their effectiveness and also to mitigate or decrease the number of side effects that patients were experiencing. Most of these drugs early on were developed in the metastatic disease setting, so patients with advanced disease. And how you would judge whether the drug was working or not was determining whether or not the tumors were shrinking when you repeated scans or examined the patient. And as long as the disease appeared to be going in the right direction and the patient was tolerating the recipe of drugs being administered, the therapy was continued. Those strategies resulted in modest improvements in outcome for patients with advanced disease. And it was also appreciated that if you used similar drugs or cocktails of drugs in patients with less advanced disease, that you may improve their outcome as well. This is called adjuvant therapy. A way that we judge whether or not chemotherapy was working is by conducting clinical trials. So in any individual patient in advanced disease, you may see an effect, but what we really want to determine is over a population of similar patients, does receiving that therapy impact on their outcome? Does it make them live longer? In patients with early stage disease, again, there is no evidence of disease when you're recommending adjuvant therapy. When those trials were initially being started, it was oftentimes adjuvant therapy versus no therapy. And the rationale, of course, was we didn't know if it worked. So these were large trials that were conducted that demonstrated that by getting adjuvant therapy, in this case adjuvant chemotherapy, patients with early stage breast cancer lived longer. And as a result, that became a standard of care for many, many years for most patients. And we, again, didn't have tailored or precision tools to help us determine who are the patients that really need chemotherapy, who can avoid it. So as an example, somebody with many, many lymph nodes under their arm or a very large tumor, it's sort of easy to say that patient's at an exceedingly high risk of disease recurrence. We should target that kind of patient for receiving adjuvant therapy. On the flip side, if somebody has a very tiny tumor and none of the lymph nodes under the arm are involved, many of those patients are cured without any additional therapy. But unfortunately, we didn't have any of the tools that would help us in a more precise way understand who the patients are that remain at high risk and may benefit from chemotherapy, even in that population where the tumor is smaller and the nodes are negative. So among the tools that we now use routinely in clinical practice are things, again, that you may have heard about, and those are things like the Oncotype test or the MammaPrint test. And these basically, are, in a simplified way, are like looking under the hood of the tumor if you're thinking about a car. And that is, we're trying to go at a much more granular level and look at the molecular makeup of the tumor. And what these tests do is they sort of distill the molecular makeup into a score that helps us determine the risk of the disease returning at some point in the future. And if the risk is high enough, that would warrant chemotherapy. Now, the other issue with chemotherapy is in the current era, we don't think of breast cancer as a single disease, but rather as a group of diseases. And we categorize or silo, in a sense, breast cancers based on certain molecular features. So there are tumors that are hormone sensitive because they have estrogen and progesterone receptors. There are patients that we refer to as HER2 positive because we can detect that HER2 feature in the tumor cell. There are some that have a combination of those two things. And there are tumors that lack any of those markers, so-called triple negative disease. And we tailor the use of chemotherapy according to what subset of breast cancer it is. So triple negative breast cancers, particularly with early stage disease, are going to pretty routinely get chemotherapy. And today we often combine that, depending on the extent of disease, to include immunotherapy with chemotherapy. In patients with so-called HER2 positive disease, we typically combine chemotherapy with what we call HER2-directed therapy. These are drugs that are antibodies or small molecules. You've heard things like trastuzumab or Herceptin, pertuzumab or Perjeta. There are drugs like tucatinib, which is a small oral pill that targets HER2. And these drugs are often combined with chemotherapy. And then in hormone-sensitive breast cancer, as I mentioned earlier, these are patients where the molecular testing helps us determine in a patient with early stage disease whether anti-hormone pills alone are sufficient or whether we need to add chemotherapy. So the way that we approach an individual patient is very much dependent upon the subset of breast cancer that they fall into. So this is a very complicated area that's evolved from one where one size fits all. We had a couple of chemotherapy drugs. Didn't matter, what your tumor's characteristics were, you would get that chemotherapy recipe. And now, many years and several decades later, how things have evolved is to look at the features of the cancer and then determine, based on those features, what the best treatment is. And in some cases, it may not involve chemotherapy at all. So I think we've made an enormous amount of progress in tailoring our therapy to produce the best results for patients. One of the new things that's coming along in the future, and the future is here, are what are referred to as antibody-drug conjugates. This is a class of drugs that have in many ways revolutionized how we take care of breast cancer as well as other malignant diseases. And they basically are manufactured to link a chemotherapy drug to an antibody. And what that accomplishes is the antibody is able to target a specific thing on a cancer cell. So as an example, HER2. If you have a chemotherapy drug attached to a HER2-directed drug like trastuzumab, you can hopefully more effectively treat the cancer and avoid some of the toxicity that comes along with giving the drugs individually. And these drugs have proven to be highly effective. And the drug development in that area of antibody-drug conjugates, or ADCs, has really exploded. So we anticipate that this will be a trend, and the result of the trend is probably over time there's going to be less chemotherapy used and more drugs like these as standard of care therapy. If you're interested in learning more about your case and what the options are, you can go to yerba.com for more granular information that may help you. So any treatment that we offer or recommend for the treatment of breast cancer, early or late stage, puts patients through a great deal. And even in patients with early stage disease who are receiving adjuvant therapy, the chemotherapy regimens are associated with side effects, and these can impact on your day-to-day life. We try to minimize those side effects as best we can, but there's little doubt that there are side effects that you would experience. We try to do everything we can to keep those to a minimum so that patients are able to maintain their quality of life and actually do the things day to day that are important to them, their family, their jobs, etc. So those things are always top of mind when we're seeing patients. We not only make recommendations about what we think will most effectively treat their cancer, but at the same time we try to do everything we can to make that treatment tolerable. Well, thank you for watching. I hope you found this useful. You can get more information at yerba.com, and we look forward to talking to you about other topics in the arena of breast cancer in the future.